Hello, I'm Matt Lyon. This is Thoracic Ultrasound Part 3. In this lecture, we're going to cover the pleura, artifacts arising below the pleura, and diaphragm. So as we talked about before, we use a systematic approach for thoracic ultrasound. We place our probes across the ribs, we identify the ribs, we identify the pleura, we look for movement of the pleura, then we look for artifacts arising from the pleura, then we look deep to the pleura. Now we want to look at the pleura themselves. So, which probe are we going to use? We've talked about this before, but for the pleura, if we're interested in the pleura itself, we would like to use the highest frequency probe available. The linear probe is generally going to be our highest frequency probe. It's going to give us our best detail and our best resolution. And this is the one we want to use when we're looking just at the pleura itself. Now the pleura are very thin. They're between 0.2 and 0.4 millimeters thick. And ultrasound cannot differentiate between these two pleural surfaces. In our diagram to the left, we can see that the pleural surfaces are adhered one to another, and we cannot distinguish them on ultrasound. They just look as a single bright line. Because there are two surfaces and they're moving one another, we can see the movement relative as sliding back and forth, as we've already covered, which is the sliding lung sign. So when we're looking at the pleura, we're thinking about, is it normal or is it abnormal? Generally, if it's thin and adherent, as we've seen before, and it's sliding, it's normal. And that's what you're going to see in the majority of times. But occasionally you'll run across something called pleural thickening. Pleural thickening is not a term that I'm applying to all of the pleura. It's generally at localized areas or plaque-like areas. So we need to look at the pleura and we need to ask ourselves a few questions. Which pleura is involved? Is it visceral or the parietal pleura? Is there extension beyond the pleura to the chest wall? Can you see the lung that is deep to the pleura? Can you see lung structures? Are these structures abnormal? Is the lung parenchyma regular or irregular? And by irregular, I mean shaggy. And are there any artifacts arising from the abnormal pleura? So let's look at a few of these. So the first one is non-specific. It's called pleuritis. Generally, when I'm scanning somebody in the thoracic ultrasound, I'm either scanning them for shortness of breath or chest pain, or both. And if I've done an exam and it's normal and they've got chest pain, I'd like to put the probe right where they say it hurts. And sometimes what I'm going to find is I'm going to find a thickening of the pleura. This could be pleuritis from an infectious cause or an inflammatory cause. I can't really tell. But pleuritis is generally going to be broadening or thickening of the visceral pleura. And the way you know that it's the visceral versus the parietal pleura is the parietal pleura is still very adherent to the rib. So we can see it in the diagram. The parietal pleura comes up under the rib and it remains a very thin line. On the ultrasound image, you can see how the parietal pleura comes right under the rib. It's the visceral pleura that has been thickened. An example to help demonstrate this is mesothelioma. This is an asbestos-related abnormality. And we can see in the ultrasound image, we can see that the pleura is very thick. We can see that it is still going underneath the ribs. So it is the visceral pleura that is thickened. We can also see these hypoechoic bulges in the pleura that help us to see the pleura itself. And this is the mesothelioma itself, which is generally cancerous and may be associated with calcifications. Calcifications are very easy to see by ultrasound, and they are very bright and they cause posterior shadowing. This case does not have calcifications, but mesothelioma often has calcifications. It would be very easy to see. In the other image, we can see a pleural effusion that helps outline the mass of the pleura. We can see this mass. It is very irregular, and we can see the hypoechoic fluid help it outline it, and we can see the lung deep. And this helps you see that it is attaching to the visceral pleura and separating the visceral pleura from the parietal pleura. Another time when you may see pleural thickening is in a pulmonary infarct, which is caused by a pulmonary embolism. Pulmonary infarcts are generally hypoechoic areas which are fairly homogeneous and generally wedge-shaped. This makes sense as you are blocking off a blood vessel and the blood feeds out laterally and it causes a wedge-shaped infarct. This is really the infarct. Because it is an infarct, it generally causes the pleural surface to bulge outward. And because it bulges outward, it's easier to see. There may also be some linear hyperechoic structures in there, which may be the bronchiole, or a linear hypoechoic structure, which could be the thrombosed vessel that you may see inside the collapsed or infarcted lung. The picture you see is fairly hard to see, but is showing you a wedge-shaped infarct heading towards the pleural surface. Let's look at a live video of one. We can see our probe is parallel to the ribs, which is not according to our systematic approach, but is so that you can see this infarct. It's generally a wedge-shaped infarct. It's wider towards the pleura and comes down towards a point. We can see somewhat normal lung adjacent to it, and we have a very large hypoechoic area with some things inside of it. Those things inside are still air-filled lung, are those punctate hyperechoic air artifacts. These are the bronchioles that are still filled with air. This is what a PE looks like. Now, when you're talking about a PE in ultrasound, we must keep in mind that a PE is somewhat difficult to see with an ultrasound. And while some studies have demonstrated good results with ultrasound in the detection of a pulmonary embolism, CT is much more sensitive and specific. Not only is CT better at imaging the infarct, but it can also image the pulmonary arteries, and it can see the clot itself. Therefore, you should not rely on ultrasound in detecting a pulmonary infarct for the diagnosis of PE. However, if you do detect one, you can feel fairly certain that there is a pathology that is going on that needs more investigation. I use this fairly frequently. A patient comes in and they are experiencing chest pain and shortness of breath. I am suspicious of a PE. I'll scan their lower extremities looking for a DVT because I know if they have symptoms of a PE and they have a DVT, then they also have a PE, and I don't need to investigate any further. But once I've done that and it's negative, then I'm going to ask them where it hurts and I'm going to scan the area of pain. If I find a hypoechoic wedge-shaped structure there, then I'm going to start thinking that that is a PE, which in this case it was. You also may see something very similar looking to a PE, which may be tuberculosis. Generally, if it's tuberculosis, it's going to be found in the upper lobes. It may be solitary and it may be bilateral. And it's very similar to an infarct in that it is a pleural-based hypoechoic lesion. It's generally not, however, wedge-shaped. It generally has subpleural pulmonary infiltrates, which I have tried to demonstrate on my ultrasound diagram. You'll also note that there is no thickening and no bulging of the parietal pleura. And the visceral pleura is very irregular and almost difficult to see. So let's look at a live video of this. So we have the rib, the visceral surface, and the parietal surface. If you look at the pleural surface, it is very smooth and normal. If you look at the visceral surface, it's very irregular and very hard to visualize because it has lots of breaks in it. Then if you look at the lung down below, it is what I call shaggy. All right, this is subpleural pulmonary infiltrates, and this is consistent with tuberculosis or a tuberculoma. Now, when you're scanning, sometimes you'll run into hyperechoic lesions. Everything we've talked about to this point has been hypoechoic lesions. These hyperechoic lesions are pleural pathology on the pleural surface itself. Generally, they're on the visceral pleura. And what they look like is a small defect in the pleura and then a lung rocket coming down from them, or a reverberation artifact. This is truly not a lung rocket, and many people confuse pleural pathologies with lung rockets. These are not lung rockets. They are not an air fluid interface, but a problem with the pleura itself. In this patient, we can see these hyperechoic lesions right along the pleura, and they slide with lung motion because they're on the visceral pleura, and they cause this reverberation artifact. The reverberation artifact is distinctly different than that we saw in lung rockets or B-lines for several reasons. One reason is that they are not stable with the pleura. They look like they appear and disappear very rapidly, and it may not even be completely associated with lung movement. It is associated with lung movement, but if you'll remember with the lung rockets, they were very smooth movements back and forth, and the lung rockets moved in the same tempo. In this case, they look like they're flashing on and off. These are very different. This case, this is disseminated MAC. I don't know the specificity or the sensitivity of this sign, this ultrasound sign, for the detection of disseminated MAC. But I do know that it is correlated. It may be correlated with other things. We haven't talked much about pneumocystis, but pneumocystis generally has lung rockets, or it looks like air in the alveoli, like cardiogenic pulmonary edema or ARDS, but it is diffuse and widespread. This is not lung rockets, and this is different, so I believe you can tell the difference between those two clinical entities. Now, we talked about it before. We talked about how the ultrasound has what's called multibeam. Well, multibeam is where the ultrasound sends out a perpendicular or straight down beam right out of the transducer. Then it sends one off at an angle. Then it sends one off at the opposite angle. And then it combines those three pictures into one picture. And that gives you a higher detailed, higher resolution picture with less artifacts. Well, occasionally you can see that multi-beam artifact with pleural irregularities. And you can see here in my schematic, you can see those three beams and they get separated out and you can see them. You can see it on the ultrasound beam too, and you can see how they're crossing one another and you get a interference pattern because of it. This is what we've named the trident sign because it looks like a trident, and it is only seen when the multi-beam is on. If you turn the multi-beam off, this artifact will just appear as a single line, similar to what we saw with the MAC example before. We don't know exactly what this means, but we have seen this in association with miliary TB. So here's an example. You can see on the image on the right, it is moving, the pleura is moving, and you can see as we increase the depth, these artifacts go all the way off the screen, very similar to lung rockets or B-lines. But these are not B-lines or lung rockets. They are at angles, and they are due to localized pleural problems. In this case, this is miliary TB. Since it's miliary, you can see this on all the pleural surfaces, including the diaphragm surface, as we can see on the image on the left. And for some reason, I don't know why, you cannot see the trident sign with the curvilinear abdominal probe when you're imaging all the way back towards the diaphragm through the liver. It doesn't look the same, but this is the same patient at the same time, and this is miliary TB. Now, you will run into pleural masses, which can be confused with all the clinical entities we've already seen. Rarely is the pleural mass benign. In fact, if it's a pleural base lesion, only 5% of the time will it be benign. And these may be lipomas, schwannomas, chondromas, and benign localized fibrous tumors. If you do see them, they will appear on ultrasound as a well-defined, moderately echogenic mass and are sometimes accompanied by small pleural effusions. I do not even have any examples of this. Other times you will find pleural masses, and you will know what they are. Malignant masses will be found in the pleura, and they include mesothelioma that we've already looked at, lymphoma, and metastasis. On ultrasound, metastasis, primarily of adenocarcinoma, are the malignant tumors most often found in the pleura. They are generally accompanied by a pleural effusion, which, because it acts as an acoustic window, facilitates enhanced sonographic assessment of the solid component. We see one here on the right. We can see these masses arising from the diaphragm, and they're surrounded by the pleural effusion, and it is very easy to see. On the left, we can see an ill-defined hypoechoic mass with well-circumscribed borders, and it is fairly difficult to see and would be easy to miss. The one on the left is a lymphoma. The one on the right is metastasis. The most common ultrasound findings for malignant pleural masses are nodules greater than 5 millimeter diameter in the parietal pleura, although sometimes they are found in the visceral pleura. The most commonly affected area is the diaphragmatic pleura, which we have seen on the right, and sonography may also show that there's chest wall involvement. And when you see chest wall involvement, you can be very sure that it is a malignant or neoplastic mass. You will also see pleural-based lung masses, and most often these are going to be malignant. They must contact the pleura for you to be able to see them. If it's well within the lungs, or if there's normal aerated lung around the mass, you won't be able to see it. If you do see a mass and it has contacted the pleura, you will start beginning to think it's neoplastic just because you found it and you need to do further investigation. But some things that help you know that it's neoplastic are that the margins are well circumscribed, as we see on the image on the left. If you see any kind of extension or finger-like projections into the lung tissue, then you know that it's an invasive cancer. If you see displacement of the bronchi or the vessels inside the mass, that is also very concerning for neoplasm. And if you use color Doppler, you can see neovascularization. Color Doppler is a useful tool for determining if the lesion is benign or malignant by demonstrating this neovascularization. You can use what's called the resistive index, using spectral Doppler, to look at the flow inside the mass. A resistive index of 0.52 has a sensitivity of 100% and a specificity of 95%. This can be very useful in differentiating benign versus malignant lung masses. However, if you find a lung mass, you really should do CT imaging, and this is really beyond the scope of this lecture. Now, the diaphragm is the last thing I want to talk about in this lecture. The diaphragm is part of the pulmonary system, and you can look at the diaphragm to see how it's moving. The diaphragm should slide back and forth with lung respirations, as we see here. The diaphragm contracts and moves the liver and the kidney down, and it's very easy to see. And when you see that, you can feel comforted that the diaphragm is working normally. If there's paralysis of the diaphragm, then that means there's loss of the phrenic nerve function. This could be from a variety of diseases, such as leprosy. It may also be associated with a traumatic diaphragmatic herniation. So if you have a patient comes in that has just had a car wreck and they don't have normal diaphragm movement on one side, you should suspect that they have disruption of their diaphragm through herniation. This is the end of part 3.